Hello, my name is Ian McCall, and this is a short talk on lentiginous melanoma. Now, this is one of the melanomas in situ, and it's probably the very earliest form of melanoma, and we're seeing more and more of it here in Australia, simply because we've got a lot of elderly people who've had chronic sun exposure, particularly on the back and face, and they have a wide variety of atypical pigmented areas. Now, the problem for the pathologist is one of assessing what degree of atypical melanocytes, what degree of atypical proliferation there is at the derma-epidermal junction. If they start to form some nests there, then it's a bit easier. A little degree of nesting is part of a lentigo maligna. But often these are reported as being junctional dysplastic nevi or Cossard's nevi. I think it's probably best if I show you some examples and then we'll go into the pathology in a little bit more detail. Let's have a little look at this. Here's a pigmented area on a patient's neck. Now, it's a large area, and there's varying pigmentation within it, so it then becomes suspicious. If it had just been uniform pigmentation, we might have said it was a lentigo simplex or a solar lentigo. When you put a dermatoscope on it, you start to see these structures here. Let's go into this in just a little bit more detail. These multi-sided structures are called polygons, and we commonly see these as a marker of lentiginous melanoma when it's off the face. Exactly what they represent, we're not sure. It may be regression because these are grey dots, and the grey dots usually represent melanin melanophages in the dermis. Now you can see within this lesion that, for instance, there are some lines curved here, and they're usually features of seborrheic keratosis, or even a solar lentigo, I should say. So where you're going to get the action here is here. And if you're going to do a biopsy in this, doing a little punch biopsy here or here isn't going to give you a true representation of this lesion. So you really need to do a shave biopsy, and you really need to include this area up here in your shave biopsy. So biopsying this correctly is very important. Let's have a look at another case. Here's a man with an area of pigmentation on his face. Now again, there's a bit of variation in this pigmentation, and that should attract your attention to it straight away. It's unlikely to be a solar lentigo in those circumstances. Now, you're looking again at this area here. Again, some scattered grey and brown dots round about the openings of the hair follicles. A suggestion of a network in this area back here, but of course you can get networks in solar lentigos as well. And if we go up a little bit higher power, again, you can see these grey dots, probably some brown ones, around the openings of the hair follicles. So what does this represent? Let's look at this one here. And this is a pigmented area in this gentleman's scalp. You can see there's some other, what I would call solar lentigos here, but this is a big one, and there's some varying pigmentation. When you put your dermatoscope on it, again, you've got these scattered grey dots and some early polygons here. Not as convincing here as they perhaps were in the other one. And some little grey dots up here. Let's see if we can make that just a little bit bigger. There we go. You can see these small grey dots in this. Now, the grey dots tend to represent regression. There's an immune attack going on here. Something's happening. So it behoves you to biopsy this correctly, and it needs a big shave. So if you look at the histology of this, though, then you'll see this picture here. And here you've got proliferation of melanocytes at the derma-epidermal junction. You might say there's several here. Is this a small nest? But normally you should have one clear melanocyte here for about 9 or 10 basal keratinocytes. And you can see you've got an awful lot more, little bit of upward spread occurring here as well. And that makes it easier, because these are the features that you would get in a lentigo maligna. But sometimes in these lentiginous melanomas, you'll just have proliferation of single melanocytes along this dermo-epidermal junction. And it's then a question of how atypical are they. Do you call that just atypical melanocytic hyperplasia? Do you call it lentigo maligna? If you follow this along and you see a hair follicle and it's going down a hair follicle as well, then that's another feature that's much more in favor of lentigo maligna. And it's one of the reasons why, if you just shave these and think, I've got rid of it all, you won't. There's still some down that hair follicle, and they'll proliferate back up the hair follicle into the skin again, and you'll get recurrences. So this was diagnosed as a lentiginous melanoma. Melanoma in situ, call it lentigo maligna if you wish, because underneath here is solar elastosis. All this bluish material that you're seeing under here is altered collagen and elastin from chronic sun exposure, and that's a feature of lentigo maligna as well. Let's have a little look at some other examples. And the best place to look is Skin Cancer College's blog. And the best place to look is some presentations from a guy called Jeff Keir. Jeff is in Ballina. He sees a lot of AIDS patients there who have a lot of sun exposure, and so he sees a lot of these lesions. Now, he presented 3 cases on a particular patient, and this was the first case with a lesion, I think, on the superolateral scapula. This is the lesion here. It's here, close up here, and you're looking at the lesion here. Now, you're looking to see if there are any grey dots, which I don't think there are with this, though it's difficult to say. There isn't a true network here. And if we looked at the histology on this, then this was the picture here. Here you've got an acanthotic epidermis. You've got increased melanin in the keratinocytes in the base of this epidermis. There are a few melanocytes here, but no great melanocytic proliferation. There's some orthokeratosis overlying this as your granular layer. So this is a seborrheic keratosis. A little bit of plugging here as well. Okay, let's have a look at the other case that we had. Here was one on the right shoulder. Now, this is the sort of patient we tend to see here in Australia. Here, a lot of sun exposure, a lot of freckling, and there's this area here. And if we look at it in a little bit more detail at the clinical, you can see some varying pigmentation here, a paler area in between, but certainly your attention would be attracted to this. And then when you look at the dermatoscopic view, you start to see these structures here, a suggestion of polygons again, gray dots, a pale area. This is paler than the surrounding skin, so it suggests there's been some regression here, that the melanocytes have been destroyed here, making it paler. And then an area up here where you've got lines curved, so suggestive of a solar lentigo or early flat seborrheic keratosis. And if you look at the histology of this case, then the pattern you see is this. So the top view, suggestion of some little nests at the end of these reti ridges here. See if we can make this any bigger. There we go. And if you look a little bit more closely, there are some atypical melanocytes here at that dermo-epidermal junction. Not really in that linear progression that we saw in the lentiginous melanomas, but in a similar sort of way. You can see there's excess melanin here, probably in dendrites, from the cells down here at the dermo-epidermal junction. But there's certainly abnormal melanocytes here. Look at the variation in the size of the nuclei here. So there's a little bit of nesting as well as some abnormal melanocytes proliferating along here. So this was reported as a lentiginous melanoma, melanoma in situ. And the third case, which we'll get to shortly, was this one on the right upper arm. I'm taking my time showing you this just to get your eye in with the dermatoscopic views as well, because these are subtle. So here's this lesion. I think we're talking this one here. There's the clinical, bit of variation in pigmentation. You put the dermatoscope on it, and again, the thing that catches your eye are these polygonal structures here. And so again, it would make you think of a lentiginous melanoma. Let's have a look at this was a couple of monitored views that Jeff did. I think they're about 3 months or so apart. Again, there were polygons in this original one anyway. This was the second one where perhaps the polygons are a bit more. These are very slowly evolving lesions. You know, some people argue that nothing much might happen with these. They may well remain like this for years and years and just slowly evolve in this way. But we're still not sure if that's the case or not. I think they are certainly slowly evolving melanomas. Let's have a look at the histology. I think these are all courtesy of Dominic Wood at IQ Pathology. Again, let's make that a little bit bigger. You're looking along this dermo-epidermal junction here. It looks to be a bit of thickening of that epidermis anyway. Something happening at this level here. That's solar elastosis. It's a nice big shave that's been done. And as you come down, you start to see this abnormal proliferation of melanocytes at the base of the epidermis here. You can see the abnormal proliferation here. It's pretty subtle though, isn't it? And then it's only when you come down to this level here, you'll see some of these abnormal melanocytes at the dermo-epidermal junction here, some of them moving up into the epidermis. You may need to do actually some special stains on this to distinguish between keratinocytes and melanocytes here in these, just to get an idea of how much upward spread there in fact is, because there may not be much. A lot of this may still be in the dermo-epidermal junction and be part of a lentiginous melanoma. So this is the sort of subtle lesion that we're tending to see. And as I say, previously, a lot of these weren't described or reported as melanomas. They were sometimes reported, if there was a little bit of nesting, as a junctional dysplastic nevus, and Cossad's name was associated with it. Let's have a little look at another case that I've got here on the back of this guy's shoulder. And you can see how extensive this lesion is clinically. There's another one at the side of it. And if you have a look at the dermatoscopy, then you can see this is a disorganized lesion. This was initially reported as a junctional dysplastic nevus, but you don't get that type of pathology in an elderly patient. If someone's presenting like this, it's an early melanoma, melanoma in situ, lentiginous melanoma. You can see the polygons that are forming in this as well. I think we perhaps have a better view of them here. So this is a contentious lesion. It's usually a very broad lesion. There's, you know, there isn't a lot of nesting. The non-nesting melanocytes will easily outnumber cells in nests themselves. And it's in chronic sun-damaged backs that you're going to see this. So that's the group to look for. I shave these. I don't really monitor them. The question then becomes, so how do you deal with this? I mean, this was a big lesion. And what sort of margins do you put on these as well? Often there is a degree of atypical melanocytes even out here. But I think in general, if you put 5 millimeter margins on these when you're cutting this out, then that's probably adequate for this sort of lesion. But with chronic sun damage and chronic sun exposure, they're just going to get more of these. What would happen if we just left them? Would they eventually develop into say a nodular melanoma, or at least develop a deep component? I think they will. I've got a couple of other examples I'd need to try and bring out to you of patients that I've in fact left, not because I've deliberately left them, but for one reason or another they haven't been seen in time. And I've got one guy in particular that developed an invasive nodular melanoma in a lesion that I would previously have described as a lentiginous melanoma, and this was over a period of 18 months. So I think if these patients become immunosuppressed from drugs that they're on or for some other reason, then these things can progress as well. But I think it behoves us to make sure we diagnose them adequately with a shave biopsy, and then to do an excision with 5 millimeter margins. Thanks very much.